Hi, everyone. I'm James Paton. I'm a healthcare journalist at Bloomberg News in London. Like many of you, I've been focused on COVID-19 over the past 18 months. The pandemic, needless to say, has dominated the agenda because of the health and economic devastation that it's caused, but we're also very interested in exploring the impact of the crisis on other areas, especially cancer, and learning more about the ripple effect that we're bound to see. And today, I'm speaking with two experts in oncology to shed light on that topic. Camille Hertzka is Vice President and Medical Head of U.S. Oncology for AstraZeneca, the global pharmaceutical company. Anil Rustgi is the Interim Executive Vice President and Dean of the Faculties of Health Science and Medicine at Columbia University, as well as the Director of the Herbert Irving Comprehensive Cancer Center at New York-Presbyterian Hospital. It's a pleasure to have you both on the panel today. Camille, let's start with you. We know that COVID has led to delayed screenings, diagnoses, treatment for many people. AstraZeneca obviously is one of the biggest players in the cancer drug market. Can you tell us, first of all, how the pandemic has disrupted your ability, the company's ability to get medicines to patients who need them, what the pandemic has looked like from your perspective?
Yeah, thank you for this question. It's a really important topic because we have seen from almost the very first months of the pandemic, we've seen that there was a disruption potentially in cancer care. First, from a diagnostics perspective, where we've seen that less patients were being diagnosed with cancer when it was not caused by the fact that there were less patients with cancer, but just by the fact that they were not diagnosed. And obviously, we know how important it is to be diagnosed as early as possible in the course of the disease when we talk about cancer. So we've really worked with all the oncology community, patient advocacy group, with medical societies, professional associations, oncologists, and various institutions to really raise awareness on the importance of going back to do screening, going back to their doctors for patients, for people who had symptoms. We heard so many stories about people having backache or something, pain, and they were just not going to see their doctors because they felt, well, that can wait a little bit longer. And potentially they didn't want to take the time of a doctor treating patients with COVID. But we know that this has impact for cancer. So we've raised awareness through a campaign called New Normal Same Cancer to bring people back to see their doctors when they had symptoms, as well as for screening and raising awareness on this important aspect. And we also know that some patients had to delay their assessment, had to delay their treatment because they were not able to go to the hospital because, again, of the pandemic. And here again, we've worked with oncologists to make sure that we've raised awareness on the importance to go back and do the assessments. So really, it has been a great opportunity to collaborate and to get all together to increase the awareness on the importance of the continuum of care during this difficult time.
Okay. And Anil, can you describe, your pandemic experience? I mean, what's the biggest way that COVID-19 has, altered the work that and the research that you and your colleagues, carry out at your medical center in New York?
Being at Columbia University and New York-Presbyterian Hospital in New York City, we were unfortunately at the epicenter of the pandemic in the mid to late spring of 2020. And that was truly unprecedented and historic, an inflection point, indeed, in our history. So as we were confronting the situation, there was no a book to follow. And so some of the knowledge gained, some of the skills applied were empiric. And from that, then, we could then set up protocols and algorithms. But areas that adversely affected us initially that we did overcome with our patients, families, and communities through a lot of education in our communities, especially to address healthcare disparities, was one, by New York State regulation, elective surgery was postponed, but some of that elective surgery was for our patients with cancers. Secondly, procedures, especially, let's say, screening colonoscopy for average risk colon cancer was delayed, and therefore early detection of colon cancer and possibly other cancers through screening modalities was being compromised. Third, our ability to deliver clinical trials was severely reduced, and that's something that we worked with AstraZeneca and other pharmaceutical companies. If a clinical trial represented a so-called life or death situation, we continued, but the preponderance of clinical trials had to be deferred, be they inpatient or outpatient. So we adopted a lot of regulations and policies to deal with that help deal with all of these issues, from screening, early detection, hospitalization, clinic visits, clinical trials, education, relationships with our communities in the second surge in the winter of 2020 into early 2021, and also somewhat of a third surge this summer and early fall, although the depth and breadth of that surge was not as dramatic as in other sectors of the country because of the high vaccination rate in the country. And frankly, because of our assiduous pursuit of vaccination and prevention measures on our campus and our hospitals, so that our infectivity rate was essentially zero.
Got it. And I wanted to, look ahead as well. Obviously, this impact, is going to be felt for years to come. What should we expect, in the fight against cancer? Are we, sadly facing an increase in deaths? Big looming costs for healthcare systems, because treatments have been delayed.
Well, there are multiple implications. The first one is indeed for patients who have not been diagnosed on time, potentially there will be an impact and we might see patients progressing quicker. However, I'm going to take maybe a little bit more of a positive look at this. I think we've learned also a lot of good things during this pandemic. We've learned how we could adjust our clinical trials. We've learned how we could simplify our ways of working. We've learned how we could collaborate better to make more impact. And we've also seen, and I think that's what we just discussed, some healthcare disparities, which already existed, but really coming to light during the pandemic. And being able to understand a problem can help to reduce at least some of these disparities and tackle it. So I think there are quite a lot of good learnings that we've taken from the pandemic, from a clinical trial perspective, from an acceleration of some of the new technologies that would help us potentially address the need of more patients through telemedicine, for example, and really look at how we could address some of these barriers of healthcare disparities. One of the first steps is understand the problem, and we are now very, very, very focused on this aspect.
I mean, we've seen, COVID exacerbate those gaps in society all over the world. Anil, how is that playing out from your standpoint? I mean, when it comes to the, inequity and inequality in the healthcare realm, are you, worried about these gaps in access, widening further, due to COVID, and how are you responding to that?
Yeah. Well, I too share optimism for now and into the future that an unfortunate set of historic circumstances has led us from pessimism to optimism. That being said, I think the solutions are there. The implementation of the solutions do take time because we're trying to transform narrative and circumstances from inequity to equity, and that unfortunately cannot or does not happen overnight. It does require large-scale cooperation between public and private sectors, societal organizations, and importantly, government at the federal, state, and local level. Alignment is absolutely necessary. That being said, we at Columbia University and New York-Presbyterian have invested tremendously in infrastructural support for our cancer patients. So more translators, especially to Spanish, but not exclusively so. Navigators to help our patients go from the community to our healthcare facilities and vice versa. The more care that we can deliver in our communities, home care as well as community centers, I think the better off we are in terms of implementation. Telehealth has increased dramatically, essentially non-existent in our healthcare system prior to 2020. And now almost 20% of our outpatient visits are telehealth. And that's been received extremely well, not only because of the convenience for our patients, but the ability now to speak to a patient with support systems, family members, friends that we can invite them in to help support our endeavors. Working with our community, we have over 40 partnerships with community organizations, and that's helping a lot. So increasing the infrastructural support, increasing staffing, acknowledging cultural and barriers, linguistic barriers, I think then have led us into a better pathway to address the inequity. And I think we're seeing success already, but there's still more to do.
Okay,
Yeah,
Anil, yeah, Camille, go ahead.
James, if I can just add one thing, which I think is also another aspect which is really important. Now that we really are getting together to tackle some of these issues around healthcare disparities, one of the focus area we have is to bring more clinical trials to diverse patients and making sure that we're more equitable from that aspect. And there are different solutions that are being built as we speak. Again, in collaboration with the different stakeholders from the institutions, oncologists, patient advocacy groups, and medical societies. And I'll just give you three very short examples of actions that we can do that can have an impact. The first step is bringing awareness on clinical trials. Not understanding what is a clinical trial is the first barrier for patients to come into a trial. So raising awareness, making this accessible to everybody in terms of understanding what is the impact of being part of a trial is extremely important. The second piece is more around unconscious bias. We know that investigators sometimes would have an unconscious bias. And so now as part of all the clinical trials that we're rolling out, we have a training for investigators. We work with all the CROs to make sure that there is a training for investigators to have a full understanding of potentially this bias. And then we know that some patients have issues with transportation to the hospital. Assuming that we are back in a context where we can go back to the hospital. And for that, there are some solutions as well where we can provide support, financial support for patients to come to the hospital when they live far away. And for patients who, for example, needs childcare support, we hear a lot of these stories about patients who have a family, they don't know how to come to the hospital because they have their children. So here again, we can provide some support. So having been through this pandemic helped us really to listen, to watch, to observe, to understand, to discuss with the whole oncology community to understand some of these barriers to be able to address some of them.
Great. And I wanted to, you both brought up technology, I think, and there's been a lot of misery during the pandemic, obviously, but I think there's also been an acceleration in terms of innovation and new ways of operating. Anil, maybe from your perspective, what do you see as sort of the biggest change on the tech front, over the past 18 months that could have a big impact going forward?
Well, at our institution at Columbia University, there's been a big focus on the marriage of technology, new types of technologies with healthcare delivery. And obviously, we're seeing that across the national landscape and beyond in other countries. So one category is telehealth. It sounds simplistic with televideo, but not everyone has access, including internet access. So for X percentage, it's seamless, but for Y percentage, it's still challenging. So we have to come up with a diverse portfolio of technologies to do outreach to people who don't have access to technologies. This is where I think working directly in the communities themselves can be most helpful and can be quite attractive. The second is the ability to monitor patients' symptoms, signs, physiological values, blood test values in a longitudinal way. So that in healthcare, we tend to think of encounters as static, but really healthcare is dynamic and it's longitudinal. So the design, implementation, for instance, of wearable devices that can monitor glucose, heart rate, blood pressure, other types of physiological activities are really important from a technological viewpoint. The third is increasing ability to provide care in the homes of individuals. It's a huge burden that it's been exposed by COVID to take care of everybody that has COVID and non-COVID. People are suffering with COVID, but people without COVID are suffering too because they're not able to get into the types of acute care they need. So if we can amplify our technologies and efforts in prevention, especially in the home setting, I think that would be very attractive. So these three modalities are something that are that I think about a lot and that we're seeing evidence of across the landscape.
Technology front, I mean, during the pandemic, we've seen significant advances in the vaccine field, especially mRNA. What are the prospects for, cancer vaccines, from your standpoint? And how is AstraZeneca going to maintain its position as, one of the biggest cancer drug makers, given that the whole industry has been transformed over the past couple of years?
Well, I think technology can apply to very different aspects. The first one is probably, as you're mentioning, from a research perspective, we will be probably able to identify more targets through artificial intelligence and machine learning, as we will be able probably to screen more targets and identify the ones that are actionable. So I think that's going to help really to accelerate a lot of our research. Beyond this, in terms of developments, telehealth is going to help also in terms of recruitment of patients. We've seen informed consents being done electronically, which is a great opportunity potentially in some cases for patients to take more time at home and really think about if they want to be part of a trial. Plus, we've seen a lot of other aspects around assessment that can be done also more remotely. So from the research perspective, there are some great plus. From the development perspective, we see also an acceleration. And then there is all this communication that we see coming up through virtual meetings. And this is also extremely important, as we clearly see now how important is the collaboration with the communities, collaboration with all the different partners that we have in the academic world as well, and patient advocacy group. We will have the opportunity to listen more and to hear more through these different technologies. And maybe one of the last one, which I think is extremely important and will help a lot in the future, is being able to generate data from the real world setting and really assess how our medicines are being used in a practical use, in the real world, in a much better way, with much more quality, probably through, again, some of these new technologies.
Okay, and we'll give Anil the last word since we're running out of time. But are there new, technologies or approaches that are emerging out of the pandemic that, could make a profound difference, in cancer that you would highlight in particular?
Yeah, in addition to all the issues we discussed, cancer vaccine as an approach is not new. It's actually been around for decades. Perhaps there have been barriers to advances in it. So not only are there mRNA-based vaccines, but for quite some time, there have been DNA-based vaccines. So I think in the next decade, we're going to see a revisitation or resurgence, if you will, of vaccine-based therapy, but it's not a new field.